Going to crack on. I'm going to talk this morning about CLL in general. Now, the CLL Support Association has this great resource and posts its talks on YouTube. So I had a look, and quite a few people have looked at the talk I gave last year. And so I'm guessing a number of you in this audience have already seen the talk from last year. So rather stressed this weekend, I was trying to change some slides around. And definitely the end bit, things do get changed around, but the beginning bit, there has to be a degree of overlap. So here we go. So starting off some disclosures, I will be presenting clinical data which is sponsored, that trials have been sponsored by different pharmaceutical companies, and I have received funding, advisory boards, paid lecturing and conference attendance. And likewise, because I present some data on drugs that are not available in the NHS clinics, there's disclosures that I also work in the non-NHS sector. So this talk, I'm going to start off by covering the blood system and the development of leukemia. I'm then going to talk a little bit about laboratory analysis of CLL. I'll talk about supportive care issues, and then we'll round off talking about CLL therapy. Now, I have to apologise from the beginning that some of the slides are inevitably a bit technical, and I'll try and explain and talk you through to make it as accessible to as many people as possible. But some of you have done your science days long ago, and you're not really going to be that engaged, but I know others of you around here, like some of my Cambridge patients who come in, and I find they've actually published some of the research data that underpinned the science that I'm talking about, and that is definitely actually true. There are all sorts who will get different bits from the talk. So whenever we talk about leukemia to a general audience, we just have to remind ourselves how the bone marrow works. So we know that deep within our bone marrows, we have this incredibly proliferative active environment. We have these very precious mother cells, the so-called stem cells, that can become anything. Almost anything within blood. So we call them those pluripotent stem cells. And they've been there since we were born or developed in utero, and they divide from time to time, and they're very, very precious, as you might imagine. But they divide and differentiate out into more specialist cells. And these specialist cells are broadly called the myeloid cells. So when you've been in clinic and your doc talks about your neutrophil count or your red cell count or your platelet count, these are all myeloid cells, and they've all developed from the original stem cell that goes down a myeloid stem cell line. Now that contrasts with the completely separate part of the blood system called the lymphoid cells. And these come from a developed lymphoid stem cell that splits into the B cell lineage, which is what we're going to be talking about today, and the T cell lineage. So that more specialist part of the blood system provides a really important part of our immune response and how we battle with the pathogens and things that our bodies will come across over the years. And then before we can go further, I just have to stress this difference between acute leukemia and chronic leukemia. Because leukemia means an expansion of white cells in the blood. And acute and chronic are very different. Acute means it's the early progenitor cells that have expanded, and they tend to race away. They pack out the bone marrow. You can go from well to desperately unwell on ITU in a matter of weeks with acute leukemia, and we see that. So it packs out with these early blast cells, so here, myeloblasts. And acute lymphoblastic leukemia is similar. That's the one that's the commonest leukemia in children. And it's packing out of those early primitive cells. And again, you can have a child that's gone well, gets a bit sniffly, losing weight, limping, ill, fevers, starts to bleed, and oh my goodness, acute leukemia. Very different timeline. The chronic leukemias accumulate these white cells often over years, and that can be decades. And so the chronic myeloid leukemias accumulate all of those ones at the bottom, and the chronic lymphoid leukemias, characteristically CLL, accumulate those B cells. So we're here to talk about chronic lymphocytic leukemia, and chronic lymphocytic leukemia is the commonest leukemia in the Western world. And the hallmark is this accumulation of the B cells that have, for want of a better term, gone bad. So these clonal B cells. And doctors, nurses, biologists, we love this term clonal, and sometimes it can be a bit confusing. But clonal just means a collection of cells that have all grown from the original mother cell. So imagine you've got your developing B cells and one goes wrong for whatever reason. And that individual cell, let's call it A1789436. Oh dear, I shouldn't have done that. Then you're suddenly going to have lots of A, whatever it was, times 1 million, times 10 million, times 100 million, and that's a clone, because all of those cells are the same, and they're divided, grown up, and then they pack out the different tissues. So you see them in the blood. On the left there, we've got a blood film. We can see those white blotchy things. I could, I suppose, oh, hang on, that was not what I planned to do. Okay, no laser. But the cells there in the blood, which are the lymphocyte cells expanding. Then there's that middle picture is one of the bone marrow. So it packs out in the bone marrow. And then the lymph glands, that's someone's armpit, where you can see a lymph gland swelling. Because these clonal B cells like to go to specific places, and we tend to say bone marrow, blood, spleen, lymph nodes. And these B cells have this very typical laboratory feature, and you might hear doctors talking about CD numbers. And this is a code. This is a code for the different proteins on the surface of the cells. And the number, cluster differentiation 5, is just what's been internationally agreed. Well, that particular protein we're going to call CD5. This particular one, CD23. Another CD20. And all of our different disorders, CLL, follicular lymphoma, mantle cell lymphoma, they're all cousins, but they have a different code. So although we might look at that blood film and go, oh, you've got CLL, we shouldn't ever really say you've got CLL until you've done the special analysis. And we call that flow cytometry. So it goes through the lab, we get that code, and we say, right, now we know this is CLL, and it's not a cousin of CLL. So the CLL, the typical patient, the commonest age, presentation around age 70. Males a bit more than females. It is more common in first-degree relatives. That obviously causes a lot of stress, but I always say it's not inherited in a Mendelian way. And if you pluck out statistics and you say, well, look, if any human in the UK, let's say, has a 1 in 1,000 lifetime chance of getting CLL, well, 4 times higher still means a first-degree relative has a 249 in 250 chance of not getting CLL. You can play with statistics either way, you see. And if you phrase it like that, you say, look, there is absolutely no point going and saying to your 25-year-old son, go and have a blood test. You never know, it might be worth finding out. It is absolutely not. If son is enjoying himself in Ibiza, actually, maybe not. Anyway, let them get on with life. Don't go and overburden first-degree relatives. But it is a medical fact that our patients are familiar with. Many of our patients are found coincidentally. The well man clinic, the well woman clinic, they've retired, or I haven't seen my GP for 10 years, I'm going to go and have a health check. And they come away with this heavy heart that someone said you've got leukemia. And of course, that would have happened to a number of you in this room, statistically, because we know in the UK, only 15% of new diagnoses are on treatment within 6 months. 85% do not need initial treatment, and many of those were purely found by chance. Diabetic review, hypertension review, all those things which happen. So CLL is very variable, and it is hard to predict at the beginning how a patient will behave. And a lot of great CLL scientists have dedicated their careers to understand this progression. David Galton, one of the forefathers of CLL, his PhD in 1963 was mapping out the different paths of CLL and how quickly CLL changed. Because some CLL patients are like a tortoise, and they come up, their lymphocyte count's 10, and then you see the next time the lymphocyte count might be 12, might be 9. And I always like to say to patients, and I'm sorry my patients, I can see you around the room, so you've heard them all before, it's like waves lapping on the beach. And you're trying to say your lymphocyte count is there, and sometimes the patients go, oh my goodness, it was 12 last time, and now it's 15, and if you're in Cambridge, that's a 30% rise, and I've modelled the exponential curve, and this means, and you say, no, this is lapping of waves. A 13 might be 11, might be a 12. Of course, if a 13 becomes a 26, it might mean something different. But some CLL just doesn't change. Some CLL potters along. This was Galton's 2A. I'm looking at my colleague, Dr. Ben Kennedy over there, who knows where the animals fit with Galton's original PhD thesis. So sometimes they potter along and can move faster. And then there are some unlucky people where CLL does just move quite quickly. quite often these patients come up to the clinic, they're more symptomatic, they've got more prominent lymph nodes and all the things we'll talk about. And you bring them back a bit earlier because you've got a sixth sense that something isn't as stable with some patients as others. So we've talked about the incidental presentation, that's the one that is the most common, but there are many symptoms that CLL patients can present with, and tiredness is one of the most challenging. Early stage CLL categorically causes tiredness, and I think we've just got to accept that is the way it is. Some wonderful patients are utterly immune to the tiredness of CLL, whereas you have others who they've got a lymphocyte count of 15, and they say, look, I'm telling you, doc, 5 years ago I'd play golf, I'd go out, I'd do this, and nothing would stop me, and now I like to have a snooze in the afternoon. Now that doesn't mean their CLL needs to be treated, and there are various supportive care issues, supportive measures we can talk about, but I think it is a problem with CLL. Weight loss, thankfully, is quite uncommon until CLL becomes more progressive. Night sweats are very variable. Some people can have night sweats for 20 years and it just doesn't bother them that much, and other people it can really cause a degree of distress. As CLL advances and it packs out the bone marrow, all that normal manufacturing capacity of the bone marrow gets squashed. So you don't make as many red cells, you get a bit anemic, your white cells aren't as effective, you get more infections. And thankfully uncommon with CLL, the platelet count can drop and cause bleeding. The lymph nodes, I've mentioned this already, and we've shown that picture of axillary lymph nodes. Again, amazingly variable tolerance. Some people get discomfort from nodes, other people don't. Some people will tolerate fairly prominent nodes, and I've learnt of old to, when a patient comes into the clinic, not go, oh my goodness, Mr. Jones, they're looking big. Because I go, hello, Mr. Jones, how are you? And they go, well, I'm fine, not so bad. I say, great. Because, of course, the rule, the absolute rule of CLL is your first conversation is, how is the patient? Don't look at the results and tell them how they are. You ask the patient, because patients are very variable in their tolerance of symptoms. But the recurrent infections, bacterial and viral, and this has really been put into focus with the COVID pandemic, has changed somewhat how we view CLL because of this problem with progressive immune failure. And it's so variable. We have some CLL patients who have no infections. And I say, but you know, CLL, are you sure? Have you had antibiotics? They say, look, doc, I'm telling you, I haven't seen a GP for 5 years. And I'm still cursing why I went for that blood test. But you have other patients who, every year, they dread the winter. And they sit there thinking, oh my goodness, what this winter going to bring? And then there are these strange autoimmune manifestations of CLL. The commonest is when a CLL patient starts to chew up their red cells, something called hemolytic anemia. Because the immune system in CLL gets messed up in many different directions. So infections is the one thing that people tend to think of, but these autoimmune chewing up red cells, chewing up platelets. It can do strange things in the skin. There's this very rare autoimmune thing called pemphigus, which is a blistering disorder. There are more common things where people, I've had patients kicking out the cat because they get those little red nodules on their leg that can be itchy, and they think it's a flea bite, but actually it's a CLL. Strange eczematous things can come and go. All sorts of things CLL can do. But it's this difference between individuals, and when we first meet our patients, trying to communicate some of these issues is quite challenging. And I think that's why these talks are really useful. I was just saying to John before I started that actually I'm being a little bit lazy in the clinics and directing people to the talks on the CLL Support Association, say, look, there's great stuff out there, because it's really hard to get this information together in your own minds. And I often say to patients from first diagnosis, it will take 4 to 6 months to get your head around. Recently I saw a patient who is in the 4 to 6 year time frame to get their head around a diagnosis of early stage CLL. But this first one, a patient of mine last week, how long have I got, doc? Because if you present in your early 50s and you've got children at school and your first thing is, you know, I've got a plan, do I have to make immediate decisions? The pragmatist, they're 65, they're worrying more about their golf handicap, and they're wanting to say, is this going to make me unwell? What are the symptoms like? Is this going to affect my quality of life? But it is an overriding factor. Is CLL going to shorten my life? And I think this is the point where I have to stress, how the world of CLL has changed. And that's going to be a theme for this, the last part when I'm talking about therapies in CLL, which hopefully can reinforce some of these very positive messages. So at diagnosis, and when we're coming to treatment, and at relapse and retreatment, we often ask this question about prognostic markers. Because prognostic markers, we're asking this thing, can we predict how an individual's CLL is going to behave over the next 5 to 10 years? So they've arrived in your clinic, new patient, or they've been there for a year or two. But it is philosophically an important question. Is it a good thing to know that, or a bad thing to know that? Because we have to think about prognostic and predictive, and this sounds a bit technical, but let me give you an example. If you take one of the best prognostic sets, you can say, well, look, there's an 80% chance 10 years from now not much would have happened to you. If you line up a lot of worst prognostic things, you can say, with heavy heart, there's a 60% chance you'd have been on treatment within 10 years and working through things. Now, forgetting the fact that actually there's a 40% chance not much would have happened to you. So 80%, 40%, which when you're looking at a big data set of 1,000 patients means 800 patients or 400 patients, so that's important. But the individual in front of you, well, if you are rolling a 10-sided dice, even with that bad prognostic, if you roll a 1, 2, 3, 4, you'll be fine at 10 years. Now, I know life is not quite that simple, but the principle is that as an individual, predicting what that individual will do is very different from prognosis of a big data set. And the reason I drill into that point is we can run a lot of molecular profiling at the beginning, but it is an important question. Is that what I want to know? Because I often have chats with my CLL patients with early stage CLL, and you've got to think, where in your car do you want your CLL? Do you want it sat in your passenger seat, chatting to you every day? Let's turn left, let's turn right, I'm going to play golf. No, not going to play golf. Do you want it in the back seat, throwing in helpful comments from time to time? Or do you want your CLL in the boot? Or, I do like mine, or in a suitcase, wrapped up, and you only open it once every 6 months when you go to your GP or your clinic and have a look at your blood test, and then close it back and carry on your journey. Because it is difficult, isn't it? It's really hard when you're trying to live your life, because you want to live your life. You want CLL to be as packaged as individually as possible. So I'm just floating that as a philosophical thing. So if you're thinking whether you should get things tested, if your CLL doctor said, you know what, you're doing fine, it might be you're better off just walking away saying, that doc says I'm fine, hurrah, on I go. So prognostic markers. So if we think about what we know about prognosis stage, the Binet stage and the Rise stage, I'm giving a talk in a couple of weeks on the history of CLL. So I dug over this weekend, I was looking at some of the original papers. Rise paper from 1975. And an interesting thing, I didn't realise that Binet's original paper was then modified in 1981. So this is actually the modified Binet stage that we all use. And I must stress that those survival figures, the bottom ones are from 1975 and the top ones from 1981, when we only had steroids, chlorambucil, and we used to irradiate spleens. So those figures do not apply, but the principle is that when CLL is more advanced, anemic, low platelets, prominent lymph nodes, patients are heading more towards therapy. So that's prognostic markers at stage. But there's loads we can do in the lab. There's a lot of interest in separating this good and bad disease biology, and then by extension, can we use that information to influence choice of therapy? If people have this molecular group, are they better suited to these treatments? This molecular group, another treatment. And to explore this in a bit more detail, we do need to talk a little bit about molecular biology. So this is why I apologise if you just get a bit lost on this, if this isn't your thing. But we'll walk our way through these 3 different areas called immunoglobulin, heavy chain mutational status, chromosomal abnormalities, and mutations of specific genes. Because you will hear people in your clinic talking about your IGHV status. So immunoglobulin gene mutations. Now, imagine this circle is a big lymph node. Your primitive, fresh, new B cells come out of your bone marrow. They're ready to fight anything. They're what we call undifferentiated, and in immunological terms, haven't yet seen any foreign bugs. They come in. They go into that lymph node as an immature B cell with this potential to recognise things. Within the lymph node, there's an anatomical area called the germinal centre, where the B cells and the T cells and monocytes and macrophages, things all come together and they speak to one another, and cells are processed and selected. It's wonderfully complex immunology, and out of the other end is spat a more mature B cell. Now, in this process, the immunoglobulin chain, so these are what make our antibodies, go from being this potential to recognise anything to super specialised mutated. And one might have an angle like that, one might have an angle like this. And there are literally billions of potential combinations because of the biology behind it. And it's genuinely interesting if anybody wants to dive into it. But the principle is that we as humans can potentially see any pathogen. So when new virus drops from outer space, or from somewhere else, our immune system, technically, there will be some people on the planet who will see that virus thing and will survive the pandemic. It's actually, I shouldn't probably speak of it in those terms now, as we've just been through such a big pandemic. But the basic principle is that our immune system has this enormous potential capacity to recognise things. And it's all in this amazing complexity of how we develop these specialist cells. But these mature B cells, these IgHV mutated ones, are the ones that go out, fight the fight, secrete the specialist antibodies, etc. But CLL can derive from either of these B cells. It can derive from the more primitive, unmutated IgHV, or it can derive from the more mature one. And those of you with CLL in this room, you will have a specific mutational profile because you can't have both. It doesn't convert. It's not like other aspects of CLL biology. So you are one or the other. And the unmutated ones, from the more primitive CLL, they divide more rapidly. They're more likely to move towards needing treatment. These are the patients who come in with a white count of 30 and then a few months later perhaps it's gone up to 60. Their lymph nodes are more prominent. They get more night sweats. They feel a bit less well. And we know historically with the old days of chemo, it simply didn't work quite as well and the patients would relapse faster. And the mutated is the exact opposite. These cells, they divide less. They often secrete less in the way of those interleukins, interferons that make people feel less well. So you can have people in your clinic that have had the lymphocyte count really high. I saw a chap yesterday, in fact, with a lymphocyte count that is now 290. He's completely well. He's got mutated CLL. It's been high for a long time. He feels really well in himself. So these mutated patients can be quite different. And we know that with the old days of chemotherapy, these are the ones who would hold those remissions for years. And this is a slide from the great Terry Hamlin's old presentation. So Professor Hamlin worked in Bournemouth and is again one of the absolute forefathers internationally of CLL and understanding the biology and treatment. And this is again very old data, but you can see these are survivals of the Bournemouth data set. This is all patients just chucked together, showing about, if you look at 10 years out, you've got about 30% of patients with unmutated alive and versus 70% with mutated. Old data, but it showed how these curves could be separated. So that's the IgHV status. The other thing CLL doctors often talk about is chromosome differences. And this is asking the simple question, are there structural abnormalities in the chromosomes? Now this is a karyotype. And the sharp-eyed amongst you would have seen that there are 3 copies of chromosome 21 at the bottom there. So this is a karyotype from a Down's syndrome individual. Because we know that you can inherit in your whole body differences of chromosomes, which can then associate with syndromes like Down syndrome. But cancers can cause damage to DNA and you can lose whole chunks of chromosomes. And CLL is one of those cancers where it's actually quite common. And in CLL, there are some commonly recurring ones such as trisomy 12. So you have 3 copies of chromosome 12. 17p deletion, that's P for petit, the small arm of chromosome 17 is lopped off. We call that 17p deletion. And actually, they're quite a collection. We've got 11q deletions, 13q, the long arm of 13q being deleted. And again, this is really old data, but the Germans showed us that actually, if you look at all the German trials, this is published 24 years ago, so long before anything like a modern therapy. And you could say this big difference in survival, so the 17p deleted doing much less well, and then at the top, the 13q, not entirely sure why, but the 13q deleted as a sole abnormality seeming to do very well. So this information we've had for quite a long time, which influences how we think about the CLL patients. So we've done IGHV, we've done chromosomes, and then the last thing of the modern technology is the mutations. And the only one I'm specifically going to talk about is this TP53. TP53 is a master regulator of cell processes. We all need TP53 because it tells a bad cell to be thrown out. Now, human biology is complicated. If you think from our brain to our guts to our liver to your feet, you've got all sorts of different cells and cellular organs that are turning over cells, having new cells, correct cells. Mistakes happen. Of course they do. When cells are dividing, you get abnormalities that shouldn't be there, and it's normal for the cell to recognise, oh, hello, I'm wrong. I had a DNA replication error, that bit sticking out here. I need to be destroyed. And TP53 is a master regulator. It sees something is wrong with the DNA, and it says, right, time to commit suicide. And that process is called apoptosis. That cell dies off. So TP53 is like the policeman saying, oh, hello, something wrong, kill this cell. So it's not hard to imagine why abnormalities of TP53 are a recurring theme in cancer. Because the bottom line is cancer cells are not dying when they should, whether it's a pancreas, a breast cancer, bowel cancer. And this thing we call perturbation of apoptosis, so failure to die when it should, is a recurring theme in cancer. And TP53 mutations are something we track down in CLL. Because when people get mutations in TP53, they can progress a bit faster. They can be more resistant to treatment. They can relapse. So that's why we tend to screen for that mutation. Now, TP53, to be clear, sits on chromosome 17p. So imagine, if you've lost chromosome 17p, so that's 17p deletion, you have lost TP53. So you're immediately down to 50% of your doses of TP53. And actually, by a quirk of biology that I'm not going to go into, often in 17p deleted patients, the other preserved allele has a mutated TP53. But we'll leave that. This is getting a bit complicated. But the bottom line is TP53 is important, and in CLL, it can be mutated or lost. The bottom panel here is from Anna Hsu, and you won't be able to see all those little letters, but Anna Hsu in Oxford has done this amazing work on genomic profiling of CLL. There are lots of genes that can be mutated, and there's a whole wealth of information which I'm not going to talk about. So finishing off this whole prognostic section tells us that good means early stage mutated IGHV, 13q deletion, and no evidence of TP53 disruption. Less good has that other side of the equation, advanced stage, unmutated, 17p, 11q, that's one I haven't touched on, but that is in there. But a lot of this prognostic marker information is less strongly predictive with newer therapies. Really important to remember that. So, no trial has ever shown benefit of treating CLL early. And that really is an important thing. So the international standard remains this watch and wait. And I know watch and wait has all sorts of things. You have something that's fantastic, don't need to do anything, on I go. When you have the other thing, how can you leave my cancer just to get worse? And of course, we have variations on this theme most weeks in the clinic. And then, is this the NHS saving money? Of course, you have to know. Even if you're in your lovely London clinic and you've got nice coffee and you can see views over the park, you're still going to be watched if you've got early stage CLL. And this is old data, but I'm just going to show on the left panel, this is the French from years ago when they took a chunky number of patients, 600 patients, half they gave chlorambucil, old-fashioned alkylated tablet. I actually had a patient who'd lived in Paris for years who'd taken, for 20 years, low-dose chlorambucil. Had done very well. The other half of this trial had no treatment whatsoever, and they did equally well. Long-term follow-up, no difference in survival, although you will note that at 10 years, the whole cohort is down around 50%. This is old data. But even in the modern era, this is very fresh data presented by German colleagues, the CLL12. And in this trial, they took patients who had genetically features that said, hello, this CLL might do a bit worse. And they were randomized to ibrutinib, the BTK inhibitor, new as it was at the time, or observation. Re-asking that question, you've got early stage CLL, but you've got a few prognostic markers that aren't as good. Should we treat you early? Might you benefit? And actually, couldn't show any difference. Look at this, 5-year survival, 93% in each arm. The patients were younger, but I think you'd agree the shape of the curve is quite different from the French curve. So it told us, going in with your therapies, even the new therapies early on, is not advised. So the watch and wait, this remains the standard of care for early CLL. So what do we do? What do we recommend? What is good for CLL patients? Well, I've got to start off by saying exercise, keeping fit. David Bartlett, who I know gave a great talk to the CLL Sports Association and was based in Duke in North Carolina, is now at the University of Surrey, and I heard him give a lovely talk to the CLL Forum last year, advocating exercise, talking about frailty, loss of muscle tone, all of these things. You can see this patient. I think those are 1 kilogram weights, because my wife's got 2 kilogram weights, and I try those. I did it for 21 days running until I got absolutely exhausted. So, but it is a recommendation that keep that muscle tone, fight frailty. CLL, as a white count goes up, could potentially induce frailty by taking out some of the various nutrients. And he's looked specifically at cholesterol profiling and things. But keeping fit, do your exercise. Look out for infections, act early. A lot of us will flag that to our patients, to primary care. If you're getting recurrent infections, then realistically, you've got to push a bit more for referrals, either into haematology or how your local network's set up. It might be via immunology. Some of our patients take antibiotics prophylactically through the winter. If patients have low immunoglobulins and meet various criteria, because it is quite strictly regulated, you can get access to immunoglobulin replacement that for some patients truly improves their quality of life. Vaccinations. Now, I emailed Helen Parry in Birmingham last night, and she was amazing. Sent just on school run. It's one of those emails from her phone to update me, because she's our UK expert on immunology and vaccinations. So I thought, let's just check I'm really up to speed. So annual flu jab, of course. The pneumococcus, that's pneumonia jab. And she reminded me that it's now Prevnar 13 or 15. Either, and then at least 8 weeks later, the Pneumovax 23. That's probably not as an effective vaccination, but the 13, 15, 23 recognises the number of serotypes that the vaccine is good for. So the idea is you split those apart. The non-live shingles vaccine, so Shingrix, now this is NHS approved for immunocompromised patients. I think it might be over 50, but if you haven't had that, then definitely go for that. Remember, you should not have live vaccines with CLL. RSV, this has just landed on us just recently. So the Department of Health is advising all 75 to 79-year-olds to have this. It's a non-live vaccine. If you're offered it, have it. I just wanted to check with Helen. There's nothing that she's seen about immunocompromised patients getting access to that vaccine, and there isn't at present. And then, of course, the COVID jab. We could do a whole talk on COVID. I'm not an expert on COVID, but I discuss it with our patients, of course. So, approaching early stage CLL. Vitamin D, green tea, turmeric. I thought I'd approach the ones that come up in conversation most of the time. So vitamin D. It is a controversial area because a number of studies appear to show that patients who've got lower vitamin D levels, they have higher cancer rates and worse cancer outcomes. But we've got to be robust scientifically and ask this question. Is this the same as saying, if you take vitamin D, you're less likely to get cancer? Or, if you're taking vitamin D and you have a cancer, you're likely to have a more favourable outcome? Or, are vitamin D levels actually a surrogate for general fitness and better outcomes? Because healthcare is really complicated. Fit people do well. It's this recurring theme across cancer. Of course, there are cruel exceptions, but basically that is a mantra. And we still really don't know about vitamin D. And this huge study was published 5 years ago in the world's leading medical journal, Vitamin D Supplements and Prevention of Cancer. And it was a randomised trial, 25,000 patients randomised. And they could show no difference in cancer. But of course, one of the flawed things is you've signed yourself up to this trial. You're either going to get vitamin D, or the dummy tablets to see whether your cancer rates and heart rates are lower in 5-10 years. And we don't know what it is, you've been randomised. The first thing many people are probably going to do is go to Boots and say, am I going to have double dose of vitamin D or normal dose? So it is always flawed. We know that with randomised trials. There were remarkable stories from the early days of the HIV trials of patients coming out and saying, look, we've been randomised to this potentially amazing life-saving drug or placebo. Well, let's all share our tablets and we'll deal it out. So we're all going to get half dose of the real thing. And you can see why people do that, because actually, you might say, I'm the individual and I have to take my chances. So vitamin D is a very challenging one to explore. But this was published earlier this year in Blood Advances, and this is from Israel, looking back at a large data set. And it's retrospective, so it has all these flaws, but asking this simple question, if you look at large numbers of patients on this large insurance database in Israel, can we extract some information? And the top curve is vitamin D. An intriguing thing for me is the red curve is vitamin D analogues. So those are cholecalciferol and all of those things which come with bone prevention strategies. And then the bottom is no vitamin D. And this is time to treatment failure. So it's asking the simple question, at 10 years, at 20 years, who seems to be still in a CLL state that hasn't had treatment? And it does seem to be vitamin D helps. And the one thing that New England Journal paper showed us, there were no calcium problems and all the things we worry about with vitamin D. Are you going to drive high calcium levels, because that's how it works with this bone metabolism, and cause other things, kidney problems. But there's no evidence. So I say to my patients, look, I don't know what the ideal dose is. These Israelis explored it a bit. But if you go to Tesco's, Boots, whatever, take your 10 microgram or 25 microgram tablet, you can take that. And there's actually quite a bit of data for vitamin D in other areas of immune health, multiple sclerosis, etc., etc. Green tea, I'm going to skirt over this quite quickly because green tea has fallen a bit from favour. And I know there was a lot of interest, if you go back in years, these large cohort studies trying to track people and saying, well, look, actually, people drinking green tea seem to get less in the way of lymphoid cancers. And there was a trial that gave quite a high dose of a green tea supplement, equivalent to drinking all of those cups of green tea a day that you're never going to do. Well, you're never going to do it. And in this trial, it showed it was relatively well tolerated, but the flag green tea supplements do cause a little bit of minor liver inflammation. And there have been these headline cases. And preparing this talk, I was going through some databases and I found 13 cases internationally that had been reported of green tea supplements actually causing major liver damage. And this chap went public because he had retired, wanted to get himself fit, and he was taking these green tea supplements. So just be a little bit careful. Turmeric. A lot of my patients take turmeric and ask me my views on it. And I just don't know. I don't know. It doesn't interact with most of the drugs we use. I think it is probably relatively safe. Our colleague Jamie Kavanagh, who works at Barts, had this very high-profile case where a patient had gone through so many lines of myeloma treatment, so that's a related blood cancer, and she went into remission with high-dose turmeric. She put herself on high-dose turmeric, and she was in all the newspapers. OAP stops incurable blood cancer with Wonder Spice. And I think this, a few years ago, really kicked off this interest. So I know a lot of patients take turmeric. But we've studied it in CLL, in phase 2 trials, in early stage CLL, giving people curcumin, which is the actual chemical compound. And we've not been able to show any responses. Does it slow the development of CLL? I genuinely do not know. I'm not really convinced of any evidence I've seen so far. But if you're taking it, and that's fine. That is fine. So when is treatment needed? Well, we've touched on some of these, the night sweats, the fevers, the lethargy, troublesome lymph nodes, changing blood parameters. I always say to my patients, most of the time, CLL treatment is a negotiated start point. We get to know our patients. We start throwing shots across the bowels, the patient doesn't feel quite so well, you shorten the follow-up. And I think the good thing of running an effective CLL clinic is you have the docs, you've got your nurses, of course, a wonderful resource, our specialist nurses, primary care, relatives. I always encourage relatives to come in because you always want 2 pairs of ears, not one, because they can keep bouncing ideas. And actually, and apologies to my patients who've been in and out of my clinic in 6 minutes, 33 seconds, sometimes the short clinics are quite good. And you say, look, I'm just going to think about this. We'll bring you back in 3 weeks. Just mull on this topic, discuss it with your family, get people in, then come back. And actually, that can be quite useful as strategy. Is it right? Is it the time right to treat your CLL? So this is the last section of the talk. I will quickly check my timeline. So, treating CLL, chemotherapy, monoclonal antibodies, the cell signalling inhibitors, which are basically BTK, and these apoptosis drivers. Remember that word I used to describe driving cell death. Now, chemotherapy, I'm struggling for a good analogy here with chemo, but let's stay with me with this one. Imagine the CLL is a light in your room. Now, that doesn't feel right, does it? Because cancer shouldn't be a light, and you'll see that's the problem of having this. But I say to my patients, you're going in the room, you want to turn this light off, because that's the CLL in your body. Now, chemotherapy is a bit like a hammer. So you're going into your room, and those of you in this room who've had chemotherapy might recognise this, and you swing your hammer around with FCR, you might hit that light. That light might be well and truly bashed. You might hit the switch. You might hit the wall, the wallpaper. But the targeted inhibitors are genuinely going for the light switch, because what we understand now about CLL is that's how they work. They've got this signal that's driving the electricity to the light. I was talking to this with my brother in the Lake District this weekend. He said, why don't you start with a black room, and that's the CLL, you want to turn the light back on. And he said, why didn't chemo could be a flame, sort of with oil, and you're walking in and you set your curtains on fire. And then, we lost that one. I think we've just got to stick. If anyone who has a great idea, because my patients in this room who've heard this one probably could do with a better one. Antibody-mediated cell death. So antibodies, these are using laboratory manufactured antibodies that target cell surface proteins. Without doubt, obinutuzumab is the CLL antibody of choice. A very highly manufactured protein product that we infuse. And those of you who have had obinutuzumab know that actually infusion reactions, particularly if you've had it as your first treatment, that shivering, shaky, that is the biggest side effect with obinutuzumab. It can affect blood counts a bit, and it can make people more prone to infection, but generally it's a well-tolerated antibody, and it kills cells differently from chemo. It locks onto the cell and it targets cell death in different ways. But the real breakthrough in treating CLL has come from these new therapies that target the actual biology that's going on in the CLL cells. So here we have a descriptive picture of CLL taken from Barbara Eichhorst's paper published a couple of years ago. And this shows the CLL cell, it's a living thing. It goes in and out of our different bits of the body, the lymph nodes, the spleen, the bone marrow, and they get these activation signals from these nurse-like cells, the T cells. They're pro-survival, saying live, live. And these signals are commonly driven down this B-cell receptor. That's what BCR means. So it's not like an out-of-control other cancer. It's this thing that almost, if you like, lives with your own immune system. And it circulates around the body. It gets this activation signal, divides a bit, potters off, and sometimes they die off, and then the other one will divide. But they're dependent on these signals to live. And understanding these pathways has led us to target these different molecules which are coloured differently here. We've got SYK, the SYK, PI3K, PI3 kinase, BTK, the target that we're really going for. And over the last 10, 15 years in our trials clinic in Cambridge, we've used drugs against AKT, SYK, PI3K. A lot of these drugs listed down the side. But it's BTK inhibitors that have really won out, because that really is the light switch in the CLL. It's this focal point that all these signals telling the cell to divide are going through. And those of you who've taken a BTK inhibitor will probably have recognised that when you start them, your lymph nodes start to shrink away really quite quickly. And often, people start to feel very much better, because even though it can push up your white count initially, it switches off the proliferative drive. So those angry, unhappy cells that are secreting their interleukins and interferons and making you feel flu-like and washed out, they can all be switched into a more benign state. Your white count might go from 100 to 150 in the first month or two, but the patients come in and say, gosh, lumps have shrunk and I feel better. And developing BTK inhibitors, Piers later will be talking about new developments and trials, but biotech and pharma, they love BTK because basically off-target activity, if you can really home in the BTK, whether it's an inhibitor or a degrader, actually you don't get a very bad side effect profile. So it's a real favourite. And that's why there are lots of ongoing developments. Now, the other big area is that whole thing about apoptosis. So this is slightly technical. Remember I said that all cells and all cancer cells survive because they perturb apoptosis. They're not dying. But a master regulator of this system is this molecule called BCL2. And BCL2 is really overexpressed in CLL. And BCL2 is sat there saying, don't die, don't die, don't die. And those really clever guys at Abbott Laboratory who developed venetoclax as this very carefully crafted protein that slots into this BH3 domain, so BH3 mimetic if you've read about it, worked out that if they can switch off BCL2, you can put in this death signal and the cells can start to die. And that's been a remarkable area of development for treating CLL, so BCL2 inhibitors. So to remind ourselves of the slightly depressing history, when I was a registrar working with Dr. Ben Kennedy, who was my senior registrar at the time, with Pete Hillman in Leeds, we were recruiting patients into CLL4 and we showed actually no difference in different chemotherapy regimens. But look at those stats. 10 years out from treatment, about a quarter of patients were alive before the new therapies. The Germans came along and showed if you add rituximab, things can improve. But if I just show you a quick couple of plots. Now, we're not going to talk so much about details just now, but these are modern era trials. This trial, people were getting acalabrutinib. And look at the right panel here, 5-year survival, estimates of 84%. Now, the average age going in this trial was age 70. And you can be a bit of an amateur actuary. If you go online, you can find the UK live tables. Either cheer yourself up or depress yourself, and you can put in your age and see what does the government think my 5-year survival is. And so you can put it in and find that if you are age 70 in the UK, there is an 85% chance you'll be alive at 5 years. And acalabrutinib, 5-year survival, 84%. And a similar thing with the venetoclax-based trial. So this is the German trial, which we'll come on to mention. But that blue line is showing us 72-year-olds, so a bit older in this trial, 5-year survival, 82% with CLL. The live tables tell us 84%. So you can say with a strong degree of confidence to your patients, look, your chances of having age-matched survival, if you are starting your CLL treatment age 72, all your caveats, your chances of it matching what you should be doing, what your mate should be doing, are pretty good, very good. And we've touched on these broad approaches, treating CLL, continuous therapy with the BTK. So those signalling pathway tablets, the BTK inhibitors, have all been licensed for continuous therapy. That can be debated. But the venetoclax-based strategies have all been licensed for what we call fixed duration therapy, where you can take the treatment for about a year or 15 months and then stop. It's quite a different conceptual thing. And this means our patients genuinely have choices, and this is what we discuss in the clinic. What is right for the patient? Because there are genuinely pros and cons of each strategy. So the continuous BTK inhibitors, so ibrutinib, this was a wonder drug. When this came along, I remember first seeing this data. And this is the RESONATE trial, where patients with really complex CLL were randomized to either ibrutinib or the old favourite antibody ofatumumab. And the survival of the ibrutinib arm was dramatically better. And we've still got one of our patients alive who had a previous allogeneic transplant, really complex CLL, relapsing. We managed to get into RESONATE and has worked through other treatments since then. But 12 years later, is still alive because he was able to get ibrutinib at that time. But ibrutinib is the first generation drug. Wonder drug as it is, it has quite a few off-target side effects, and there have been significant developments with the new drug acalabrutinib, zanubrutinib, and these new ones coming on, pirtobrutinib, that Piers will touch on, which have a cleaner kinase profile. So I've taken this from a paper published last year by Thompson and Tan, and we look at this kinase, these off-target effects. So what, by mistake, is the drug hitting? And then we get a bit of a different feel for what side effects might be. And as haematologists, we learnt about a target called Circ terminal kinase. I'd never heard of that kinase, but it turns out it's what ibrutinib hits by mistake that affects electrical wiring in the heart. And it can be modelled in mice. You can switch this thing on, switch it off, and give heart arrhythmias to mice. Sounds a bit strange, but that's what you can do in the lab. And so we are getting more of an understanding as to what some of these off-target effects can be. So I'm just going to briefly go through some of the trials that influence the treatment that you might be on, or you might have discussed with your CLL doctor. So the Elevate-TN, this is the big randomised trial looking at acalabrutinib. And the patients are randomised to either having acalabrutinib on its own, so these are tablets twice a day, ongoing, or with the additional of the obinutuzumab, or the blue one is this chemotherapy. And then this is looking way down the line. So this is 6 years later. This data was updated at the American conference last December, and we've got another update coming through. I've been very lucky to be part of this trial from the beginning. AstraZeneca are based in Cambridge, so we were involved early on, and I've been part of the writing group. And this progression-free survival curve, just to translate, we're looking at this curve, and this is telling us that 72 months, i.e. 6 years from randomisation, if you started the red one, acalabrutinib, there's a 62% chance you are alive and still in remission. So remember, alive and still in remission. This is a progression-free survival plot. The light blue is acalabrutinib combined with the obinutuzumab. It's a point of great frustration for us that that is not approved in the NHS. It is a popular strategy used in the private clinics, and there's all sorts of complex reasons behind it. It is a bit frustrating. We haven't yet got access to it. And the bottom one is the old-fashioned chemotherapy. But acalabrutinib as first-line treatment has become increasingly popular. And these are the survival plots. So you can see so different from those old survival plots. So acalabrutinib, median age 70, at 6 years, 76% chance that your patient is still alive. And the other fantastic thing about these BTK inhibitors is the poor risk groups are not so poor with BTK inhibitors. And this is, again, this is a bit of data to look at, a bit packed together, but the red solid line and the red dotted line are the unmutated IGHV and the mutated. So in the days of chemo, you can see the black, the chemo, how the mutated ones do so much better than unmutated, what we were talking about earlier in the talk. But with the new continuous BTK inhibitors, it's very hard to separate out mutated from unmutated. And likewise with TP53, what is wonderful to see is with the new inhibitors, patients with TP53 mutation, 17p deletion are doing so much better. So that's a really important good news point about these new drugs. The side effect profiles, the new drugs, so acalabrutinib and zanubrutinib, are basically better tolerated drugs, and I think it would be quite unusual in the UK to start a patient on ibrutinib monotherapy because there just isn't the need. We've got the new drugs, Acala and Zanu, which are basically better tolerated. I've just done some plots looking at side effects over time, so atrial fibrillation, this is the cardiac thing, and high blood pressure, which we can definitely see acalabrutinib is better. And we've seen that with some of our patients who are struggling with hypertension on ibrutinib, you can move them to acalabrutinib, and they've often been able to come off 1 or 2 different hypertensive medications. But I've concentrated on Acala, and that's a bit unfair on Zanu, because Zanu is another highly effective second-generation BTK inhibitor that some of you in this room will be taking, well tolerated by many patients. And in the zanubrutinib relapse trial, so this is a relapse trial that I wasn't part of, but they're updating the data every year at ASH, and this has now shown a progression-free survival for zanubrutinib over ibrutinib. So yet another reason to remind us why I don't think we'd be starting ibrutinib for treating CLL patients nowadays. And then side effects again. Zanubrutinib does seem very clean from a cardiac perspective, so in terms of risk of causing heart problems, seem very low with zanubrutinib. The blood pressure signal might perhaps be a bit different, but that's data as it comes. So in effect, the BTK inhibitors, they're good drugs to use. Most of our patients tolerate them well. Of course, there are specific side effects and quirks of each one, but they tend to work across the genetic subgroups, and they are commonly used. But they don't clear out the bone marrow. I think that's just an important point to just reflect on, that they're putting the CLL to sleep, And the reason they're licensed for continuous therapy is that concern, if you stop them, does your CLL wake up again? Now, that might not actually be the case. And we've got some UK data, fascinating data, looking at patients who stopped ibrutinib after 6 years and actually being really quite surprised how actually the disease seems to have gone to sleep in many of these patients. So BTK inhibitor continuous therapy might well be challenged. And there are trials looking at this now saying, well, actually, if your patient's been on the drug for 3, 4, 5, 6 years, and they're done really well, should you actually think about stopping them and then leaving the patient off drug for a while and restarting at progression? But that's a separate point. So the last bit about this talk, which I'll just finish off, talking about driving cell death with venetoclax-based therapy. So venetoclax, as I say, drives this apoptosis and it permits this fixturation strategies. And some of you in this room would have had venetoclax combined with obinutuzumab. So this was a great German trial, and it randomized patients to 12 months venetoclax with antibody or 12 months chemo plus antibody. And lo and behold, if you got the new drug, you did better. So 6-year progression-free survival of 53%. So good data. The slightly frustrating thing is with these fixturation therapies is lo and behold, the unmutated IgE reach patients start to drop off the curve. Very frustrating. The mutated ones are still up there. So that old bit of biology we talked about in chemo perhaps is resurfacing a bit with these fixturation therapies. And the Germans ran a more complex trial in younger patients, so these are 61-year-olds on average, and this was a huge trial, 900 patients randomized to chemo, venetoclax with rituximab, venetoclax with obinutuzumab, and the red line is what we're getting in the clinic today. So the red line is looking at patients long-term who've had obinutuzumab with venetoclax, doing really well. And then that left panel, sorry, this is a lot of data, but I think it's just important to include, just to remind us, the unmutated, you can see how that red bar dropping down, whereas the mutated, see how high that is. That's 5 years out with very few relapses. And it's one of the reasons driving us for the mutated IGHV patients. This is a very effective and appealing strategy. The unmutated is still a very effective treatment, and particularly for younger patients, it's a fixturation therapy and therefore appealing. But there is this ongoing relapse risk when you stop. So we've talked about BTK inhibitors and BCL2, so why not put them together? And many trials have done this, and NICE have approved ibrutinib combined with venetoclax based on this GLOW study. And I had the joy and the stress of presenting this at our America meeting last December, the ongoing follow-up of this trial that, again, we've been closely involved with from Cambridge. It's a small trial, older people trial, but they were randomized to ibrutinib and venetoclax. So this is saying, look, we've got 2 drugs that work. Why not throw them both together and then track the patients? And this is telling us 4.5 years out, 2/3 of patients are still in remission who had ibrutinib and venetoclax. I apologise for skipping through these a bit, but it's a fixturation therapy. And lo and behold, the unmutated IGHV ones are still relapsing when you stop. Then again, see your mutated doing well. So it's this recurrent theme that if you have the mutated IGHV, the fixturation ones perhaps suit you a bit better. And there's a quirk of I plus V. So this is an older patient's trial, and you can see how the survival rates for the I plus V arm drop off early on in the trial, and then there's a crossover. So the first 2 years, you were better off getting the chemo. And that's because of a degree of frailty. There were a reasonable number of frailer, older patients. But ibrutinib venetoclax, I always say to my patients, has to be taken seriously. It does have more side effects, more risk, more infections, and complications, cardiac risk, all these things which have to be assessed. So there was this early excess death. But then the survival rates seem really good. So you get yourself through that, it might be your immune system has chance to regenerate. So long term, you might do better. You can see lots of different things to keep discussing with our patients. And I can't finish a talk. Oh my goodness, I know I've overrun a bit, John. Wicked me. The FLARE trial, because it's such an amazing... Pete Hill and Tal Muneer presented this in America last December, and it's published in the New England Journal, and it is an amazing trial. It is wonderfully complicated. It is so complicated that I just can't summarise it in complexity. But the bottom line is, in this randomised trial, you got your I plus V, those two drugs, for between 2 and 6 years, so it's extended treatment, and it was based on how well you responded. But look at this amazing data. So these are young people, 62 years old, with up to 6 years of I plus V, and the relapse rates were really low. And the tantalising thing is, this is the unmutated. So finally, we have that more challenging group of patients who seem to have a really low relapse rate. So if you can give extended I plus V, which unfortunately we can't, but if you could, you would get these types of results. So, my last couple of slides, we have to make decisions. We have our patient factors, we have the CLL factors, we've got the medication factors. This is what brings the CLL doctor, their nurses, their patients together, discussing all of these issues, because every patient is different. And the biggest discussions we have when you come into treatment is, am I heading for fixed duration or am I heading for continuous? And there are pros and cons of each. A lot of particularly younger people just like the idea of saying, I'm having this for a year and stopping. And then I have a lot of other folk who say, it doesn't bother me in the slightest taking a tablet. I've got patients who have been on acalabrutinib for over 8 years now, 8.5, and they just say, I never think of CLL, I just take the tablets. But other people don't like that concept. Are you better off packing your treatments up front than having a period off to reduce resistance? Or do you accept the counter-argument of cancer biology that actually keep your treatment going, keep your CLL clones small, and then it's less likely to develop? It's less likely, it has fewer cells to have that chance of developing resistance. You can see you've got Darwinian strategies, so Darwinian resistance against clonal evolution. Lots of competing arguments you can have with your patients. But the bottom line is, there are amazing options. No matter whichever you choose first line, you've got other options second line. So whatever you choose with your CLL doctor, I'm sure will be right for you. But just remember, our data is so much better than it was. So we're not as good at the immune failure side. We still don't know how we can change the early natural history. Piers has lots to talk about with the new wave of trials that are coming, and 75 slides. It was too many, John. John did email and said it's too many. I said, that'll be fine. Thank you, John.
Yeah, excellent.